Thank you very much, Senator, and thanks to the committee members. I appreciate the opportunity to comment on the future of VA research. After 35 years of federal service, I retired from the VA on September 30, 2025 as the Executive Director of the National Neurology Clinical Programs. My testimony expresses my own opinions, informed by my years of VA service, my experience as a VA researcher, research supervisor, and mentor, and as current president of the Nonprofit Association of VA Neurology Services. Research provides the hope that our children and their descendants will lead longer, healthier, more productive lives in the future. VA investigators, as has already been mentioned, have done great things. They developed the radioimmunoassay. They established liver transplantation and anti-rejection treatment. They contributed to the implantable cardiac pacemaker and developed the nicotine patch. VA-led research has particularly focused on advancing rehabilitation, functional electrical stimulation, powered prosthetic limbs, and advanced prosthetic arms. VA-funded basic research established the scientific foundation for the first mechanistically new therapy for pain in over 20 years. VA is a recognized national and international leader in implementation science research. These accomplishments and many others have clearly benefited veterans and us all. However, recent changes within VHA have the potential to adversely affect the future of VA research and other VA services that benefit from the VA research enterprise. The approximately 2% proposed average cut across FY 2027 in the research budget is unfortunate. While it may seem modest on the surface, the impacts are likely greater than the magnitude suggests. The NIH projects an approximately 2.7% rate of biomedical research inflation, so the loss of research purchasing power is closer to 5% than 2%. At a time when other traditional funders of research, such as NIH, are undergoing major changes, the VA research budget takes on even greater importance. Even including VERA offset support, research expenditures represent only about 1% of the total VHA budget. This small investment in the future of veterans' healthcare clearly has yielded enormous returns. Funding and protected time for research in VA, as well as access to the wealth of clinical and genetic data available within the VA integrated healthcare system, has been a reliable incentive to attract and retain highly skilled researchers, including physician scientists in difficult-to-recruit specialties such as neurology, who otherwise would be unlikely to consider a VA career. These physicians also deliver care to veterans that is often only available after lengthy wait times in the local community, if it is available at all. Without them, specialists wait times will lengthen and access will decline. VA remains essential to training the next generation of healthcare practitioners. Fellowships that train subspecialist physicians include both clinical and research work. The research component requires an active research portfolio and experienced intramural mentors supported by VA research funding and protected time. Without this, VA will not be competitive in attracting fellowship trainees. Also, certain programs like CDAs provide critical early career bridge, enabling young investigators to propose research and launch their VA research and clinical careers. Another concern is the current work environment and culture within VA. Given the perception of changes within the VA system, recruiting clinicians of all sorts is becoming increasingly difficult. Current policies and staffing models prioritize clinical care of veterans appropriately, but often to the detriment of the other congressionally mandated missions, including research. Clinicians interested in incorporating research or teaching in their practice will look elsewhere if such careers are no longer tenable in VA, especially given the lengthy hiring process and less competitive salaries. Additionally, cuts and hiring restrictions are adversely impacting essential research staff. The current way of counting VA physician staff puts VA medical centers that employ research-engaged physicians who divide their time between VA and an academic-affiliated institution at a disadvantage. The current push to move a larger proportion of veteran care to the community also works against human-centered research in VA. Veterans referred to multiple community practices do not learn about relevant VA research, denying them the opportunity to participate. Their data are lost to the VA system. Decreased participation deprives veterans with serious medical conditions of treatment options and delays progress in VA clinical research. In summary, veterans, the institution of VHA, and the public have benefited greatly through VA's robust research program over the years. Congress wisely established the 4 missions of VHA: clinical care, education and training, research, and emergency preparedness. These vital missions are mutually supportive and to a considerable extent inseparable. I respectfully request that the VA research mission continue to receive robust funding and policy support, both for its own sake and to allow the other VA missions to succeed. I've submitted some additional testimony as written materials only. Thank you for your attention.
Thank you, Doctor, for your appearance before us today, and now Ms. Carruthers.
Thank you, Chairman Moran, and to the other members of the committee. My name is Gina Carruthers. I am the president and CEO of the Prostate Cancer Foundation. We represent the largest private research philanthropy in prostate cancer, having been founded in 1993, when in fact there was one drug that treated prostate cancer, androgen deprivation therapy. We've raised more than $1 billion since 1993 that has gone directly to research for therapies that will extend the lives of men impacted by this disease. That has generated today, under our seed funds, at least 16 FDA-approved therapies. I'll give you a bit on the prostate cancer's impact on our veterans. Prostate cancer is the most common cancer in our U.S. veterans. There are about 200,000 veterans who are living with this disease. About 15,000 are diagnosed each year and treated within the VA system. And I'd like to emphasize that prostate cancer is not screened for in the VA. In the U.S., it's largely not screened for at this time, but it's important to note that the program that we talk about today, POPCAP, is actually targeted for advanced disease. That's disease that has left the prostate because it's not been diagnosed in its early stage. The POPCAP program has been developed specifically to address the men whose disease has moved beyond the prostate. And this is where men are at great risk for death from this disease. The way this program works is that we take genes from the patient, their DNA, and we also, when we have biopsy tissue, take the biopsy tissue and look at somatic mutations, those specific to the cancer itself. This allows for targeted treatments specific to either the man's DNA or, in fact, to the cancer's DNA, to then be targeted to treat and extend the life of that patient. I'll give you a background on POPCAP. To fill the gap in 2016, the Prostate Cancer Foundation pledged $50 million to pioneer a large private-public partnership within the VA, and that's where POPCAP came from. The result was a network of centers of excellence, and that's been addressed a little bit. They're invested in both clinical and research teams that work on genetic testing and counseling